Why we had Sir Winston come and even speak to us in the first place. I think newer TDOers might benefit from understanding the context of what happened during the early 2000s, and perhaps it might provide some insight into what is happening today in endodontics. There was quite a bit of discussion about this post from Tim, especially when you consider the patient didn't even need a treatment to begin with. So it made me think that our specialty perhaps is under the same kind of attack that it was in the early 2000s. So let's revisit my Death of Endo lecture I gave during the microscope wars, using the same slides I used at the time. So if you'll bear with me, I'm going to go through some of that material, and maybe it will provide some insight into what is actually happening today in endodontics, as well as understanding what I was trying to do by having Sir Winston come out and talk to us about how prosthodontists think about dentistry, how they do their treatment planning, and what some of the problems are with endodontics in relation to treatment planning. After hearing this, I'll let you decide whether such billing puts our specialty at the same kind of risk as it was during the microscope wars. So where was endodontics in the early 2000s? I called it endodontics under attack because we were. Why were we under attack? Well, the leadership of the AAE was controlled by the Michigan model endodontists. These people believed and practiced in assembly line endodontics, insurance-based prescription endodontics, believing it to be the future of our specialty. Phil Cohen, the future president of the AAE, once told me, "Your way of practice is over, Carr." At this time, the AGD was putting pressure on the ADA to decertify us as a specialty, and we almost were decertified. People don't know that today. And implant technology was expanding dramatically and seen as more predictable than endodontics. And there was evidence in longer-term studies on endodontic surgery that the success rate was really only about 50% if you looked at longer-term studies. So this was a tremendous threat to us. I remember giving a course out at Kevin Mullins where one of the Dietz endodontists was there from Detroit, bragging to everyone that they could do anterior endo in 12 minutes and didn't even need to put a rubber dam on. This is an endodontist bragging that a rubber dam wasn't even necessary because it actually slowed them up. So I'm wondering if we're facing the same kind of challenges in our endodontic environment today based on that billing statement. I use this case as an example of the degree of dysfunction. It was a referral from the postgraduate director at LSU during the Katrina disaster. The patient had suffered a home loss in New Orleans and had come to stay in Newport Beach during the Katrina cleanup. They were referred to an endodontist in Newport Beach for an endo evaluation. The patient reported that the endodontist took one look at the x-ray and said, "You need to go to an oral surgeon and have surgery done if you want to save this tooth." The patient had kind of a funny feeling and called Ron Lemon back. Ron called me and made the referral. This is the x-ray from that patient. When I saw the patient, I found her description hard to believe. So I called the endodontist in Newport Beach, and he confirmed, "That's how I manage calcified canals." If you can't see how this kind of mindset doesn't threaten our specialty, then you need to find another line of work. But even more importantly, if you allow this to happen without fighting back, you're going to lose your specialty, trust me. I'll go through the case briefly. It's just kind of a routine case, really. So this is the tooth when she came in. And when we went in, which is kind of a normal treatment, really, yes, there was a calcified canal, but nothing that we don't see every single day. These are the final pictures on it. But it's emblematic of what problems are in our specialty. Now, Newport Beach is a very upscale community. Any endodontist in that community should be able to provide specialty level care. If they can't or won't, we're not going to have a specialty. By 2000, I had developed a retreatment practice, but it wasn't your typical retreatment practice, because when I went in and actually queried the cases, almost half the patients that I retreated, 46%, was actually done by an endodontist. The prior treatment was done by an endodontist. And when we actually queried those treatments done by an endodontist, only 5% of them were deemed accurate. So for me, this really was a tremendous threat to our specialty. If we didn't make a change in how we worked our patients up and treated them, my feeling is we were going to lose our specialty. So I spent a lot of time lecturing on that. This is one of the slides from that lecture. Added to this insult, you had famous prosthodontists giving endodontics a very hard time. For example, a prosthodontist who was like a god to general practitioners talked like this.
Has this happened to you? Look at this mouth with buildups, posts and cores, implants I've done. What if one of those built-up teeth that has endo in it constantly has lingering pain? My suggestion, take it out. Retreatment occasionally works. Retreatment often doesn't work. I'm going to base an entire rehab on a tooth that continues to have pain endodontically? No. I'm much better off to take it out and put an implant in or do a fixed bridge.
Carolina had an even more radical approach.
Success rates for root canal therapy vary from a low of 53% to a high of 95. It's actually about 98%. If the endodontist that you're working with has a success rate of 53%, don't you want to know why? Let's look at endodontic survival analysis. We know through some classic studies by Kakahashi that a root canal system that is infected with bacteria will develop a periapical lesion. We see it every day. We know it happens. If you haven't read Sjogren's study from 1997, it's very clear. If you have a periapical lesion associated with the x-ray, the success rate for the root canal therapy is reduced between 10 and 20%. What does that tell you? And a very recent study, 2003 in the JADA, suggests that a patient with a periapical lesion that has type 2 diabetes is less likely to have a successful outcome from root canal therapy than one that's not diabetic. So heaven help the poor person with type 2 diabetes that has a periapical lesion associated with it. Not looking good for them. What do you do in it instead? Let's look a little further. For our specialist colleagues, got to give them their due. The success rates for endodontists vary from about 75 to 98% with a mean of about 87%. But let's face it, there's 12 studies that show that if you combine the data. But let's face it, let's give them their due. They probably do the hard cases, the curved roots, the retreatments, all the stuff that we or our restorative colleagues or general practitioners don't want to do. They deal with the garbage. For general practitioners, it's not as good. Success rates for that group of people vary from 59 to 91%, but these are probably the easier cases. And there's a mean of about 82%. See where I'm headed with all this? Keep in mind that every implant system commercially available today has got success rates that's better than that. Why in the heck would you do a root canal on a patient when you can take the tooth out and put something in that you know is going to succeed at a higher level? Think about it. So my thought for the day. If an endodontically treated tooth requires periapical surgery, and yes, that is a surgical procedure, wouldn't it be better and more predictable to take the tooth out and place an implant? What are you doing to your patient?
You may laugh at this and shake your head and wonder, but the truth is, we brought this upon ourselves and deserved it. The AAE deserved it for what they did to our specialty. So I called up my friend Sir Winston and asked, why do prosthodontists think and talk like this? And he said, well, there are two major reasons. First of all, these people form opinions because of their experiences with their local endodontists. And secondly, endodontists have a disease. It's called the one-tooth endodontic syndrome. They treat by prescription, without thinking and without really looking at the whole mouth. or even asking, where will this patient be in 5 years, in 10 years, in 20 years? If you look at who endodontists were listening to back then, and even today, you can get a feel for where our mindset was as a specialty. For example, this ad from Real World Endo brags about completing 7 molar endos in one visit, a daily experience in his office apparently. This ad is from Barry Musicant. He boasts about gaining total mastery of single visit endo if you just come to his one-day course. Even more offensive is this from Ace Garrett, boasting about speed, working 3 days a week, and sailing his sailboat around the world. These are endodontists talking about how easy endo is, how fast it is. And of course, the AGD was watching all of this. General dentists picked up our message naturally. So this whole Michigan model thing was our problem for our specialty. And my feeling was we were going to lose our specialty. So Sir Winston's second point about the single-tooth endodontist syndrome is just as much a problem today, perhaps even more of a problem than it was in 2000. So my purpose in asking Dr. Chi to speak to us about where all these perceptions of endodontics and endodontics came from, I think Dr. Chi's exhortations about looking at the whole mouth and where the patient would be 5, 10, 15 years in the future resonated with many of us within the TDO community. But for those who weren't present to attend those lectures, or for those never exposed to his lectures, this is a threat to our specialty today, whether you recognize it or not. So maybe history is repeating itself. However that may be, I hope it may be helpful for some to understand better why I had Dr. Chi speak to us and how it helped the TDO community be the best version of itself.